it's essentially, in layman terms, inflammation of the brain. Now, the mechanisms here are varied. However, essentially, they translate clinically with altered mental status. Of course, you could have a gamut of other clinical manifestations as well, but this is primarily how a layman would describe encephalitis. I like to keep things simple. So when we look at the causes of encephalitis, I think infection is, of course, one of the top DDs whenever we think of encephalitis, particularly given the Indian subcontinent and the know-hows of tropical infections here. But of course, from what I have understood in the recent past, is this concept of encephalitis, particularly the autoimmune aspect of it, is rather fluid. Our understanding to begin with was very rudimentary. Of course, now there's great development in terms of understanding what the etiopathogenesis of encephalitis could be. It could essentially range from autoimmune. You could have demyelinating brain diseases as well that produce encephalitic like symptoms. You could also have autoimmune infections like SLE, Hashimoto's that trigger encephalitic like picture. So I'll start off with a case. Now, I think the audience should understand that I'm a rather lazy person. So what I mean by this is I always go ahead with retrospective learning. I see a case, we work it up, we brainstorm, give a set of differentials from whatever, limited knowledge we have, which is essentially very finite at this point in time, and then move on with how exactly the patient responded to treatment XYZ. Of course, we do the elaborate workup, and then I go back and read the literature. So let's start this presentation with this one case. So let's assume for all practical wanted to reveal the diagnosis, but let's see what happened to the patient 4 months, post the initial index presentation. So essentially, what we see is those areas of involvement which we saw as flare hyperintensities. Some of them have progressed to encephalomalacia and gliosis. And we do see new areas of susceptibility involving the posterior temporal cortex and more exaggerated, rather profound appearance of the susceptibility in the insular cortex as well. So now, essentially, why I wanted to show this case was, as radiologists, I think we do need to mirror with what is happening exactly at the pathological aspect in the brain tissue as well. So it's essentially a rad path correlation. That's what I like to call it. So initially we have the inflammation phase where there is of course proliferation, there's recruitment of neutrophils, and then it progresses mainly to involve the lymphocytes as well as the macrophages. But these essentially infiltrate the cortex of the brain parenchyma as well as the arachnoid, but they're rather also concentrated around the blood vessels, which is why we do see some areas of exaggerated susceptibility. And these eventually progress to microglial activation, forming small clusters, which basically mean that the brain is now dead, and there could be a component of demyelination as well. So moving back to what we saw, so initially what we saw was the inflammatory phase, where we saw this extensive flare hyperintensities involving some areas of the brain. And then we also saw some areas of exaggerated susceptibility, and these areas basically ended up dying. So with this in mind, we will now venture into what could exactly cause these encephalitis. Now, infection is, of course, one of the top contenders in the Asian subcontinent. And amongst infections, it is the viral etiologies that, again, are very, very notorious to present with an encephalitis-like picture. So, starting off with HSV encephalitis, again, this presumably, I think during my residency, I essentially equated infectious encephalitis to HSV, which of course is wrong, but that's how common this virus is. So basically, HSV virus is essentially neurotropic. So it starts off with some kind of, affliction to this virus, either via the mucosa of the oral cavity, or you could also have vertical transmission, which usually happens in neonates with HSV2. Now, they tend to be latent in the trigeminal ganglion. Upon some kind of reactivation, they spread to the neuroparenchyma. So again, one of the most commonest, etiologies when it comes to infectious encephalitis, particularly the viral spectrum, would be HSV. And again, synonymous to that would be the involvement of the medial temporal lobe as well as the insula. You could also have variable involvement of the thalamus, as is seen here in this case. And the affected areas could also show variable diffusion restriction. Now, again, what is important with respect to infection is the asymmetricity as opposed to what we will see in some of the further cases of autoimmune encephalitis, where it tends to be rather symmetric. So as you can see here, although there's affliction to both the cortices, they tend to be rather asymmetric. Of course, there's involvement of the insular cortex as well as the medial temporal lobes. In addition, you also do see the involvement of the basal ganglia as well as the thalamus. Now, like I said, HSV2 is something that is transmitted via the maternal genital tract, and these usually are restricted to the neonatal age group. Now, again, going back to the pathophysiology aspect of it. Now, as opposed to most of the other viruses that we saw, HSV tends to affect the cortex in such a way that there is direct invasion of the virus to the cerebral cortex, and this essentially instigates a component of ischemia. So, what we initially see is cortical laminar necrosis, and this essentially culminates into cystic encephalomalacia and dystrophic calcification. So as you can see here in the initial images, you do see swollen cortex and white matter. And then you do see areas of diffusion restriction involving multiple areas of the cortex, and these eventually essentially translate into cystic encephalomalacia, much like other viruses. But again, I think this is a very beautiful case where we do see variable infiltration of the temporal lobes, particularly on the right side where you do see swollen cortex. There's also effacement of the sulci size. So we do know something very sinister is happening right there. There's also variable inflammation, which is essentially evidenced by this contrast enhancement, which we do see along the sulcal spaces. There's diffusion restriction as well, which of course, as you see here, is asymmetric. Now, this essentially translates into cystic encephalomalacia in the later stages. And we also do see this T1 hyperintensity, which is essentially a telltale of imminent cortical laminar necrosis. So, having said that, this was one of the cases that was presented to me at one of the neurology MDTs. So, they gave me a history akin to encephalitis. So, I told them, yeah, I think I'm looking at uh, probably HSV. That's my favorite, still remains my favorite through residency and, even now. And they did say that there was this dubious history of fever, XYZ. So I said, yeah, it could be HSV and encephalitis, but we do keep autoimmune as well in the background because some autoimmune encephalitis could present with a HSV-like picture. But then, so they agreed with it, and they went ahead and performed a couple of tests. Came back to me, a few days later, and told me that I think we missed out on one of the clinical features. The patient has bilateral parotid gland swelling, and that's when I said, okay, maybe I should rethink the differential here. Of course, it's encephalitis, but I did rethink in terms of what the etiology was, and I suggested mumps encephalitis, and lo and behold, this did turn out to be a case of positive mumps encephalitis. So I think it's important to keep in mind that these are essentially doppelgangers when it comes to how precisely they present to you imaging wise, but you do keep a set of differentials in these cases. So moving on to VZV encephalitis. Now, unlike what we saw in the HSV and also the mumps encephalitis picture, in VZV encephalitis, primarily because this virus does also have this propensity to cause vasculitis, you do see areas of infarction which present in such cases. Like in this case, we have essentially, let's assume that this is not vasogenic but cytotoxic edema. I haven't included the DWI images, but I just want you to go with this. That this is diffusion restriction in the left basal ganglia, which is essentially evidenced here as T2 hyperintensity. And in addition to that, what we do see in such cases is this imminent, this sort of short segment narrowing that you see on top. So this is essentially a case of FCA secondary to focal cerebral arteriopathy secondary to VZV vasculitis. Now, VZV is notorious to cause this kind of a picture, and I always encourage my residents to get a TOF MR, particularly when we do have the relevant clinical history, which is very seldom. But in cases of the right clinical history, I think it's very important that you do get a TOF and also vessel wall imaging in such cases. Now, again, VZV is also notorious to cause spinal cord infiltration in the form of myelitis. You could have some kind of PL enhancement, as is seen in this case. with VZV encephalitis. Now, Epstein-Barr virus is not so common, but I have come across this virus turning out to be positive in my recent practice, and that's precisely why I included this in today's presentation. Now, again, Epstein-Barr virus to me was previously was just synonymous to Hodgkin's lymphoma, nasopharyngeal carcinoma, Burkitt's lymphoma, etc. But we do have, a certain sect of society that does present with this virus as the inciting agent for encephalitis. So essentially, in terms of imaging, it is not, flabbergastingly different from what we do see with other viral encephalitis, but just a positive case of EBV would reinforce what I'm trying to say here. So, as is pretty well visualized here, there's infiltration of bilateral basal ganglia. We do see some involvement of the MCPs, the brainstem, and you could have variable infiltration of the spinal cord as well. Now, measles, so something that is very unusual to the Western society is subacute sclerosing panencephalitis. If only they knew how, common it is in the Indian subcontinent, they wouldn't really call it a rare phenomenon. But what I would say is rare with respect to measles is the acute measles spectrum. I have as yet to, establish a diagnosis of acute measles encephalitis in my practice, but we do see, a case or two of SSP probably every week at the center I work at. So essentially, acute measles encephalitis, it starts off in non-immunocompromised patients, primarily children and adolescents. Now, like I said, acute measles encephalitis is a rather rare phenomenon. If it's rare in a continent like India, then I'm guessing it's rare in the other parts of the world as well. So the data with respect to the imaging findings of acute measles encephalitis is rather sparse. So what has been told is there could be infiltration of, affliction of bilateral putamen as well as the caudate nuclei with variable involvement of the centrum semiovale. Of course, you could also have, cerebral venous thrombosis, which is quite common with other infections as well. So this is a reference case. Now, what I want the audience to know is take this with a pinch of salt because the findings here could also be seen in a case of SSP as well. In fact, in my clinical practice, I've come across these findings in SSP as opposed to acute measles encephalitis. So essentially what we see is involvement of the cortex as well as the subcortical white matter and the deep white matter. Now this could be variable, it could be asymmetric. In most of the cases that I have seen with SSP, they turn out to be asymmetric. Now, what is precisely more important for us to understand is when you look at the ADC picture, the area on the right side is showing reduced ADC as well as the area on the left, which is showing facilitated diffusion. So this is essentially what I want to show in terms of how these conditions evolve over time. So there could be multiple areas of affliction and also multiplicity in terms of the age of affliction as well. Now, as could be expected, you do see some kind of leptomeningeal enhancement on the right side, which is not seen on the left. Now, again, what we see on the left is this area of gliosis, which is appreciated better on T2. Of course, I didn't add the flare images, but as you can see, the sulcal spaces on the left side are rather open as opposed to the FA sulcal spaces on the sulcal spaces on the left are open as opposed to the FA sulcal spaces on the right. So moving on to SSP, I think it's one of the most commoner, cases of encephalitis that we encounter at NIMHANS. So these are said to be common in children, but we have encountered cases of adults as well presenting with this sinister manifestation of measles affliction. Like I said in the previous case, again, the affliction of the areas of the brain that we saw involved in the previous case could also be involved in SSP. I wanted to show this case primarily because I did also want to show that perfusion does have a bearing in the diagnosis of encephalitis. So this patient essentially presented to us at 5 years of age, and she had a very, dubious history of infections, seizures, and then followed by encephalitic-like presentation. So really, when she came to us, this was the imaging picture. But what really caught our eye was we weren't really able to pick on the diagnosis of SSP at the first time point because this was a rather angry looking brain. As you can see, there's the corpus callosum looks rather diffusely involved. It's very bulky. It's very angry looking. Of course, there's infiltration of the brainstem as well, bilateral MCP pons. There's profound infiltration of the brain parenchyma. But what really caught our attention was this differences in the affliction of the different part of the brain in terms of the time point of imaging. So As you can see on T1 weighted images, there's areas of cortical laminar necrosis. Now, what's really important for us to understand with respect to T1 is some of the areas that are showing T2 hyperintensity are showing complete inversion on T1, meaning to say that this has been happening for quite some time. In addition to that, there's infiltration of bilateral basal ganglia, there's infiltration of the thalamus, the subthalamic nuclei as well. And few areas are showing stark cortical laminar necrosis, and some of them are showing encephalomalacia. We then went ahead. The thing with me is when I really don't know what's happening in the conventional sequences, I go ahead and perform perfusion as well, and contrast also was administered because really that might help us with the diagnosis. And we picked up the raised perfusion in bilateral basal ganglia as well as the brainstem. So at that point in time, we thought, is it possible that, of course, there were multiple other, reasons for us to believe otherwise, because, there were areas of encephalomalacia and gliosis. So that is not very in favor of a malignancy, but we did think of the possibility of, something sinister happening. And so we got it biopsied, and this turned out to be a case of SSP. So we are working on, how perfusion helps us, particularly in the diagnosis of SSP, because of course SSP has four different stages, and we would like to know if, perfusion is quintessential or quinone to any one of the stages. But yeah, I think we have seen that perfusion does help in terms of diagnosing autoimmune encephalitis. It also does help in this case is just a reiteration to see that perfusion could also help you in diagnosing viral encephalitis. So moving on to viral zoonosis, we have rabies now. Again, I think with the diagnosis of rabies and encephalitis, it's very important that you have the pertinent clinical history. Now, essentially, the virus here replicates in the muscle and infects the motor neurons that innervates the muscles and then essentially spreads to the CNS by means of retrograde axoplasmic flow. So you have two types of canine rabies. So you could either have the furious, which is the encephalitic form, or you could have the paralytic form. So in paralytic, of course, there's infiltration of the medulla and the spinal cord. That's precisely why the patient is deemed as the cerebrum, the limbic system, as well as the brainstem. So now this was a case that was brought to us, and with the classic features of encephalitis, patient had altered mental status, history of fever, XYZ, all the classical features. Of course, we got the history of dog bite much later, but really what I'm trying to show here is this very angry looking, basal ganglia, and there's also involvement of the thalamus as well here. And as you can see, there's variable areas of diffusion restriction as well. So now what's really important for us to know is you will not be able to make a diagnosis of rabies just by looking at the picture because there's no imaging signature of viral encephalitis. Of course, you know that when there's variable infiltration of the basal ganglia and thalami, you should err on the side of viruses, particularly in our country. But you should also go back and ask for history of, dog bite, particularly in younger patients, and also when you see infiltration of the brainstem. Rabies, much like VZV, also tends to have affliction to the spinal cord. As was seen in this case, you do have, cervical cord myelitis as well. Now, moving on to the rather commoner one, I think Japanese encephalitis is something which is an entity that is quite common, commonly encountered in various parts of Asia. So here, essentially, it's the zoonosis, and the basic cycle of transmission involves a mosquito, pig. Of course, you have the bird somewhere, and the man acting as the incidental dead end host. With respect to imaging, there is nothing Herculean in terms of diagnosing a JE encephalitis. As you see, there is usual infiltration of bilateral thalami. You do have hemorrhagic lesions, of course, in cases of Japanese encephalitis. But what I really wanted to emphasize is that in addition to involvement of the thalami, you could have involvement of the cortex as well. So this is the index standpoint imaging in 2014, where you do see involvement of the thalami. There's also involvement of the cortices bilaterally. Over a period of time, those areas of affliction effectively turn into gliotic areas, as is seen as volume loss in bilateral thalami as well as the cortex. And moving on to the scan at 2023, you just see, gliosis in those areas. Of course, dengue again is synonymous with essentially the donut sign that you see in cases of dengue encephalitis. Of course, it is a non-neurotropic virus, but we do have an increasing number of studies on CNS affliction as well. Now, again, what is important with respect to the pathophysiology of dengue and encephalitis is that the neurological involvement in this infection, it can occur due to metabolic alterations such as liver or kidney dysfunction, or you could have dyselectrolytemia as well. So double donut sign, I think, is a very, very common sign, and it's presumably, held synonymous with viral hemorrhagic afflictions, most likely dengue. But what I wanted to show is that you could have other, patterns of affliction as well with dengue encephalitis. As you can see, there's variable affliction of bilateral temporal cortices here, and these areas are also showing diffusion restriction without any, telltales of microhemorrhages. So this could also be one of the imaging manifestations of dengue encephalitis. Of course, moving on to HIV. Now, with HIV, it's pretty simple. You either have, HIV encephalopathy or you have PML. Of course, with HIV encephalopathy, it's predominantly the memory loss, which occurs over a period of several months, rather insidious kind of a picture. With HIV encephalopathy, of course, with PML, depending on the area of involvement, you could have focal deficits and other areas of affliction as well over weeks to months. Now, what's important with HIV encephalopathy is, essentially there's rather symmetric infiltration of bilateral periventricular white matter, and you do see some sparing of the subcortical U fibers as opposed to PML. So with PML, what's essentially happening is there's a latent infection. There's a focus of latent infection which begins in the oligodendrocytes of the central nervous system, and that essentially results in a lytic infection upon reactivation that tends to destroy the myelin it produces. So essentially it is, at the base level aspect, at the microscopic aspect, it is a demyelinating leukoencephalopathy which commonly presents as white matter lesions in the central nervous system. Now, as opposed to what I showed in cases of HIV encephalopathy, in cases of PML, you have asymmetric affliction of the subcortical white matter as well. Now, initially with PML, at the initial time point of imaging, you could have an absolutely normal looking T1, but over a period of time, as the disease essentially establishes itself, you have T1 hypointensity. Now, with both HIV encephalopathy and PML, you don't see any kind of enhancement. Of course, this is very different if you're dealing with a case of iris, which is immune, the reconstitution inflammatory syndrome, when you do see mass effect and also enhancement, which is very unlike the quintessential PML and HIV encephalopathy. Of course, CJD is something which is very common as well. Now, basically, I wanted to show this case because this is one of the youngest cases of CJD we diagnosed. So this is a 13-year-old boy who was brought to us with hyperphagia and acute onset psychotic symptoms. So we saw the brain and we thought it looked very, very, very striking, very, very strikingly similar to what would what a CJD would look like in cases of adults. But we were very wary because it's just a 13-year-old kid, and really we were not very sure if it could be CJD. I did also give a differential of fulminant SSP as well. But this did turn out to be CJD. So just a reiteration that you could have these sinister diseases occurring in very young patients as well. So speaking of viruses, I think we often tend to forget that you could have bacteria and you could also have parasites that can present with encephalitis-like picture. So this was a case of acute amoebic meningoencephalitis in an immunocompromised patient that presented to us. So when we looked at it, we initially thought that, okay, we are looking at a very sinister pathology here because the patient was essentially bedridden in the ICU. So we knew that whatever had affected the patient was a rather notorious organism. But what I really wanted to show is, at times when you see these areas of involvement of the brain where you do see variable microhemorrhages in those areas and also leptomeningeal enhancement. Of course, fungal is something that pops up in our head, but we should also consider the possibility of amoebic encephalitis in these cases and ask for the relevant clinical history because usually these patients tend to, they have a very sinister prognosis, but I'm not quite sure if an early detection would help, but definitely in terms of radiological differentials, amoebic encephalitis should also be a top contender, particularly with this kind of an imaging picture. So moving on to the rather amusing aspect of the presentation, autoimmune encephalitis. So a few years back, I think about 5, 6 years back when I was a resident, autoimmune encephalitis to me was just synonymous with medial temporal lobe hyperintensities. So anytime I saw medial temporal lobe hyperintensities, I called it autoimmune. If I saw temporal lobe with insular cortex involvement, I called it HSV. So this was just how restricted my understanding of encephalitis was at that point in time. Of course, now there's been a paradigm shift in how the world looks at it, and of course, how I interpret these disorders. So one of the fundamental things in terms of being able to understand what's happening in the brain is the composites, the building blocks of the brain, which are essentially of course, we will be decoding each of these in as a
Recording in
radiologist. For me, it
progress.
is important to tell my clinician if the pathology that I'm looking at, if I consider the possibility of an intracellular antigen as opposed to a cell surface antigen. Now, this is not a Herculean task. It is just basic common sense. Now, if you have an antigen which is sitting inside the cell, you need access to the intracellular antigen. Of course, the steroids and the plasmapheresis you give would not be very efficient in terms of being able to attack these intracellular antigens, as opposed to an antigen that is sitting on the cell surface. So when you have antibodies that develops to the cell surface antigens, and when you basically administer steroids or plasmapheresis, it is much more likely that your medication is going to be effective in terms of being able to target these antibodies which are sitting on the surface, as opposed to the antibodies that are essentially inside the cell body. So, like would be expected, group 2 patients with group 2 autoimmune encephalitis tend to do much better on treatment as opposed to those with group 1. So when I really look at the definition of autoimmune encephalitis, it is essentially a group of auto-antibody mediated disorders. So of course the targets, like I said, could be intracellular or cell surface. Now, what's more important for me to understand is that the clinical features could include a gamut of abnormalities. The patient could have behavioral alterations, psychosis, seizures, memory disturbances, gamut of other things, as well as movement disorders. Now, this is, just the diagnostic criteria for, particularly with respect to how the clinicians view in terms of being able to diagnose autoimmune encephalitis clinically, as opposed to an infectious etiology where the chronology of symptom onset would probably be within weeks. Autoimmune encephalitis would have a rather subacute onset where the progression is of a rapid progression of less than 3 months. Of course, you could have other disorders where you have progression over several years as well. Patient could also have a memory deficit, altered mental status, or psychiatric symptoms. Now, what's more important for us to know is that in addition to this, you should also have one of the following. Either you have new focal CNS findings, seizures which are not explained by, a known seizure disorder, CSF pleocytosis, and also you have the imaging telltales. Of course, what's important to know with autoimmune encephalitis is once the disease process sets in, it has a very rampant course. Now, for definite autoimmune limbic encephalitis, you have a subacute onset. You should have subacute onset. Of course, the symptoms here should be suggestive of involvement of limbic system. Again, bilateral brain abnormalities which are restricted to the medial temporal lobes. Of course, again, CSF and EEG telltales of autoimmune encephalitis, and also affliction of the temporal lobes and reasonable exclusion of alternative causes. Now, as opposed to these, it was not my intention to bore the audience with these terminologies, but what really I wanted to convey with these two slides is that with respect to autoimmune and NMDA encephalitis, although NMDA is, of course, a subset of autoimmune, NMDA could have a very rapid progression. In addition to, of course, having other major groups of symptoms such as psychiatric symptoms, you could have speech dysfunction as well, movement disorders, seizures, and autonomic dysfunction. So, NMD encephalitis could sort of startle the clinician. Of course, a very seasoned clinician would be able to make a diagnosis of NMD encephalitis at the outset, I presume. But it could have a rather rampant course as opposed to the other sets of autoimmune encephalitis. Now, I'm really blessed to be surrounded by very, very inquisitive residents. Of course, they are brilliant. So, one of my residents walked up to me and asked me this question as to why we have this, skewed predilection of the hippocampus or the limbic system in particularly in cases of autoimmune encephalitis. And that's when I got to reading, some aspect of the pathophysiology. And this is what the literature says. So many of the neuronal surface or synaptic proteins targeted by autoantibodies, particularly NMDA, Casper, and also LG1, are highly expressed in the limbic system, particularly in the hippocampus and the amygdala. So this precisely explains why memory, behavior, and also seizures are disproportionately affected in these cases of autoimmune encephalitis. Of course, the limbic system is also said to have very unique blood-brain barrier properties with relative leakiness around the periventricular and also the medial temporal structures, which precisely makes these areas vulnerable to immune-mediated injury. Now, the other thing that is, I think this is somewhat commonplace in our understanding that the hippocampus and amygdala are glutamate rich, hyperexcitable networks. So, antibody mediated synaptic receptor dysfunction produces profound effects here. And lastly, of course, you have paraneoplastic triggers. So tumor antigens, particularly ovarian teratomas in anti-NMD, autoantibody encephalitis, and also viral triggers like particularly HSV can also trigger post-infectious anti-NMDAR encephalitis. They basically tend to cross-react with epitopes in the limbic neurons. So it's a concept of molecular mimicry that directs the autoimmune injury to the limbic circuits. So, so in terms of how this presents, correlates clinically would be, patient presenting to you with memory impairment, variable psychiatric symptoms, behavioral changes, as well as seizures. So, like I said, with respect to the classification, what's important is that, we try to dichotomize into whether it is your group 1 or group 2. Of course, if either or both turn out to be negative, then, we are on the side of seronegative autoimmune encephalitis. Anatomy classification is primarily just, a visual uh, take on the different areas of the central nervous system that could be affected in cases of autoimmune encephalitis. Then, of course, we have the etiology classification, which I have been speaking about till now. It could be idiopathic, it could be post-infectious or paraneoplastic. So now, like I said, when we look at the anti-tumoral immune response against intracellular antigens by, the antibodies, so these essentially result in irreversible loss of neurons. So these are associated with underlying malignancies, and they tend to have a poor prognosis, of course, because the antigens are inside the cell, as opposed to the cell surface antigens, which, of course, could also be associated with a tumor or a viral infection, most commonly HSV. But the important thing to know is that these have a better prognosis and also response to therapy. Now, this was something I covered in the previous slide, just a reiteration that you could have involvement of the limbic as well as the extratemporal involvement, which essentially culminates in the following clinical presentations. So coming to the intracellular antigens, now anti-Hu is of course said to be one of the most commonest form of autoimmune encephalitis with relatively poor prognosis. But what's surprising to me is that I've never really encountered a case of anti-Hu autoimmune encephalitis. So I will show a reference case here. So essentially what they show here is a proven case of anti-Hu autoimmune encephalitis related to small cell lung cancer. And essentially here you just see some subtle, dubious, probably I would call it, increased signal intensity in bilateral medial temporal lobes. But moving on to the antibodies that I have encountered in my clinical practice. So we have anti-MA and anti-TA antibodies. So these are essentially expressed in neurons and also testicular tumors, non-small cell lung cancer and breast cancer. They could be, of course, associated with other paraneoplastic neurological syndromes as well. So now we had a middle-aged man present to us with subacute onset ataxia and also cerebellar signs were present. Now, of course, we got the brain MR and we knew exactly why, the patient had a particular set of clinical features. Because, of course, we do see this profound flare hyperintensities involving the the cerebellar parenchyma bilaterally. And we did see this leptomeningeal enhancement as well, and some of it was also nodular. But what really caught our eye was the extensive microhemorrhages that we saw in bilateral cerebellar parenchyma. So really, at this point in time, we didn't know if we should just call it um, a tumor? Are we looking at leptomeningeal carcinomatosis, or could it be a case of vasculitis? Because we had never really encountered microhemorrhages in this propensity, particularly with respect to encephalitis. And of course, the clinicians were also a little perplexed at this point in time, and we did extensively work up the patient, and it turned out to be a case of MA2 positive autoimmune encephalitis. Now, again, something that I would like to emphasize here is once you know that you have a paraneoplastic antibody positive, you do go on this massive hunt to figure out what exactly is causing that, what exactly is instigating the release of these autoantibodies. So you extensively work up the patient and perform ultrasound. In our centers, we do get a whole body PET as well to look for the primary. But in the event that the patient turns out to be like there's no tumor that you're essentially looking at, in those cases, what we do is we follow up the patient over a period of 5 years, because there's literature evidence, and also of course we have clinical expertise with this in terms of being able to identify the tumors much later than when the paraneoplastic encephalitic presentation happens. So it's very important, particularly in cases of positivity of the paraneoplastic antibodies, that you do follow up the patient over a period of probably 6 monthly, over a period of 5 years, so that you don't miss out on any underlying malignancy. So again, another intracellular antigen, we have the anti-GAD. Now, anti-GAD, of course, is a commoner one that I've seen in my clinical practice. But what I want to say with respect to GAD is that anti-GAD could be associated with absolutely no malignancy. So the patient could have no malignancies as well, just autoimmune conditions, precipitating diabetes mellitus type 1, and also Hashimoto's that could present with positivity of anti-GAD antibodies. So this was a case where we had an intracellular as well as a cell surface antigen, where we had an anti-NMDA, anti-GAD positivity in this case, and the patient also had hypocalcemia secondary to hypoparathyroidism. Now, as is very starkly visualized here, there is affliction of bilateral medial temporal lobes. There is also affliction of bilateral insula. And higher up, we do see, some amount of affliction of the frontal and parietal cortices as well. Now, again, what's important with respect to autoimmune encephalitis is over a short period of time, you see this gross volume loss. That's again one of the telltales for a radiologist to think along the lines of autoimmune encephalitis, where you see this profound volume loss over a very short period of time. So again, it's a red herring for us to think of autoimmune encephalitis in such cases. So this was another case of anti-GAD. Now again, this case was important because I wanted to highlight that particularly with anti-GAD positivity, it is said that it's very notorious to um, afflict the cerebellum, and as can be very beautifully seen here, there is extensive cerebellar atrophy. Now this patient to begin with was a 35-year-old lady, and she just had complaints of imbalance and tremulousness, with a few episodes of anxiety and reduced memory here and there, but this was over a period of 3 years. So again, emphasizing on the clinical presentation and the timeline is very important for us to be able to figure out as to what type of encephalitis we are looking at. And of course, we got a PET done in this case as well, where we do see the hypometabolism involving bilateral temporal poles, and we do see, this extensive hypometabolism involving the cerebellar cortex as well. So moving on, again, another, paraneoplastic antibody here. So anti-UO antibody, which is again something which is said to be associated with testicular tumors. Now, I'll just give you a brief insight as to how the patient presented. So the presentation was rather acute in that the patient had seizures, almost a status epileptic kind of a picture over a period of the past 48 hours. But really, what got us thinking was when we asked for clinical history. There was history of weight loss, and there was other history suggesting that the patient could have an underlying malignancy. So of course we did the workup and got the PET and all of that done, but the PET was absolutely unremarkable. So this was one of those cases where we had the antibody positivity, and of course we had imaging evidence of encephalitis as well, in the form of this a variable affliction of the cingulate. There's involvement of the insula, there's involvement of the parahippocampal gyrus, basifrontal lobe, as well as bilateral temporal lobes. But again, what's important for us to know is that just the reinforcement of what I just said, that even in cases of unknown neoplasms, it's with paraneoplastic antibody positivity, we should follow the patient up for a considerable amount of time before we actually, stop looking for the underlying malignancy. Again, this also has a bearing in terms of how the patient are treated. So I was having a conversation with one of the neurology residents at my center, and I was just asking them, how do you really treat a case of paraneoplastic encephalitis? So she said that the best way to treat a case of paraneoplastic encephalitis would be to actually remove the primary malignancy, which is instigating it, which really, if you think about it, is just common sense. You remove, treatment in such cases. So, just I just wanted to show how these cases are worked up at our institution. So, of course, there's the clinical history provided, and then there's the radiological differentials that are given to the clinicians, and then they do these extensive workup. Of course, you work up the normal blood parameters. In addition to that, you also look at the ANA profile and look at the serum and the CSF autoimmune encephalitis profile as well. Now, what's important for us is sometimes you could have more than one etiologies. You could have two mutually exclusive entities affecting the brain, but more often than not, you could have an infection and an autoimmune, kind of an etiology existing at the same time. So they do there's involvement of the basal ganglia. In this case, you could have mesial temporal lobe involvement as well. Now, again, how I know the structural imaging, sometimes you could have an absolute, the clue is the PET, and as you can see, there is metabolism involved. So, because your structural MR could be absolutely normal looking. Now, with NMDA, I think what is important is for you to be able to go back and look for the associated, you know, malignancies. Now, although I did say that, cell surface antigens respond remarkably well, NMDA is one of those cases where, the underlying instigating factor is usually an ovarian teratoma or an ovarian neoplasm. So this is just one of those cases where we had a female presenting to us with an encephalitic-like picture. Of course, we had imaging evidence of, the temporal lobe involvement uh, to suggest, the suggestion of autoimmune encephalitis. But again, as a radiologist, it is important for me to go back and look for the associated pathologies. Like in this case, we went back and got a CT and MR done, and as you can see, we do see this adnexal lesion with some amount of fat-like density on CT, and that turned out to be a case of ovarian teratoma with positive anti-NMDA. So, like I said, in these cases, it is important that you treat the underlying instigating factor for you to be able to treat the encephalitis. So, of course, on follow-up, the patient did beautifully well, and the ovarian teratoma was also treated, and so was the autoimmune encephalitis part of it. Now, this is a case of Morvan syndrome where, of course, there was positivity of more than one autoantibodies. This was a case of Casper as well as LGI1 positive autoimmune encephalitis. Now, again, reiteration of why it is important to perform PET in these cases. So, as you can see, the structural MR is absolutely pristine looking, but the FDG PET shows this diffuse hypermetabolism involving bilateral basal ganglia as well as the thalamus. Of course, whole body PET turned out to be negative in this case. Now, this was, one of those cases where we definitely had imaging evidence of encephalitis, clinical evidence of encephalitis, and we knew we were dealing with autoimmune encephalitis at this point in time, but really the workup turned out to be negative. So you could have seronegative autoimmune encephalitis as well. So imaging wise, there is asymmetric affliction of the thalamus. There's involvement of the hippocampus, the temporal cortices. Again, hippocampal involvement is seen bilaterally. So it is rather starkly evident here. There's bilateral involvement of the hippocampi, asymmetric involvement of the thalamus, as well as the cortices. So, just, how some of these can also show diffusion restriction, as is seen in this case. There's restriction involving bilateral hippocampi as well as the temporal lobes. So, like I previously suggested, like particularly in cases of autoimmune encephalitis, over a very short period of time, you could have profound volume loss. So, if we go back, the index imaging was actually performed in August of 2022, and by the time the patient was re-imaged at December 2022, although the patient did improve clinically, imaging-wise, it's rather sinister in terms of the amount of volume loss that has occurred. So, moving on to now the LGI1 antibodies. So, in my clinical practice, the most common form of imaging manifestation in this sect of autoimmune encephalitis would be the involvement of bilateral hippocampi. Now, particularly when I have to commit to the involvement of bilateral medial temporal lobes, I do get an ASL because I know in cases of autoimmune encephalitis, if that area of brain is involved, it more often than not pops up as bright cherries on ASL. So this is just a reinforcement of why ASL should be performed in such cases. Again, another case of LGI1 positive encephalitis where you do see remarkable involvement of the right, temporal lobe, hippocampus on the right side, and you do see this raised perfusion there. But again, structurally, if you see, the left doesn't appear to be as much involved on flare, but you do see raised perfusion on ASL sequences. So, another set of antibody-mediated disorders with respect to cell surface would be the GABA B. Now, GABA B, again, as you can see here, it's a rather, mundane looking picture, but you do see subtle hyperintensity involving the left hippocampus, and otherwise it's a pristine looking brain. Now, when we got the follow up 6 years later, it's just important for us to realize that some of these patients do remarkably well. And as you can see, this is one of those cases where there isn't as much volume loss as would be expected in a case of autoimmune encephalitis. Now, this is a proven case of VGKC positive autoimmune encephalitis. Now, the patient essentially was on monthly plasmapheresis and did remarkably well. So, another imaging manifestation of anti-VGKC would be again infliction of bilateral medial temporal lobes. So, now the whole point of reinforcing bilaterality and symmetricity in cases of encephalitis is to reinforce the fact that bilaterality and symmetricity is in favor of symmetricity rather than bilaterality is in favor of autoimmune etiologies as opposed to asymmetric ones that could be seen with the infectious etiologies. Now, again, something that I've also noticed is that paraneoplastic autoantibody mediated autoimmune encephalitis can present with rather sinister imaging findings, like I showed the cases of in the previous cases before. You could have variable nodular enhancement, you could have microhemorrhages as well. So a few years back, I was attending ECR, and there was this quick session on autoimmune encephalitis, and one of the concluding slides was that if you saw microhemorrhages, you should err on the side of infection. But what really I'm trying to emphasize here is that even with paraneoplastic etiologies, you could have some degree of microhemorrhage deposition as well. So I think it's pretty obvious, the diagnostic approach that I wanted to reinforce by the end of the presentation is something that I've been trying to reinstate through my presentation. That initially, it's the clinician who's going to point you towards actually looking for imaging features of encephalitis, and they basically confirm either multifocal or focal brain disease with respect to what is seen on MR and also EEG and FDG PET, rule out the differential diagnosis, confirm inflammatory causes as well, and lastly, screen for any associated neoplasm. Now, like I said, the gamut of just CNS structures that could be affected in cases of autoimmune encephalitis or encephalitis in general is rather magnanimous, as opposed to what I thought as a resident. And of course, I hope the audience, takes away that essentially any part of the brain can be affected, but it's rather skewed in terms of its affliction to the limbic system. Now, at the very beginning of autoimmune encephalitis, I showed this picture of the composite structures of the central nervous system. Now I basically wanted to reinforce that any part of the central nervous system, any aspect, any component of it could be affected, and that essentially translates it into it could translate it as presentation with autoimmune encephalitis. So one such would be the Suzak syndrome. Now here it is an endotheliopathy, which basically means it's an evolving microangiopathy. So we had this case of a 32-year-old female who presented with history of headache and vomiting over a period of 1 month. And but over the last 2 days, she had fever and altered sensorium with some meningeal irritation. So of course, the MR was done. And initially, if you just look at, the T2, some would err and call it multiple sclerosis. But really, what I wanted to reinforce here is that if you look at the areas of brain that are involved, this is cotton wool appearance of the corpus callosum. And the structures of the brain involved are basically the white matter. And these lesions essentially show diffusion restriction, which basically mean to say that there's some kind of vasculitic or a microangiopathic process that's occurring here. Move on, you also see infiltration of bilateral basal ganglia, cerebellum, and none of these lesions, the topography is not akin to what you see in case of multiple sclerosis. So again, one of those cases where and arteriopathy can also present with, an encephalitic-like picture. And it's very important that you call this Suzak as opposed to calling it a demyelinating condition. And of course, go back and ask the clinician if there's any history of sensory neural hearing loss. Does the patient have any kind of vision loss as well, which is known to be well associated with Suzak syndrome? Now, MOGAD, again, as the name suggests, it is an oligodendrocyte glycoprotein antibody associated disease. So, now, not all MOGAD essentially is going to present to you with an encephalitic-like pattern. So we had this 17-year-old male who came to us with left focal seizures and mild fever over a period of 1 week. So essentially, when we initially saw the CT, we said that, okay, it could be subarachnoid hemorrhage or leptomeningitis. I'm not really sure, but there's some hyperdensity there along the sulcal spaces. We got the MR, there was flare hyperintensity, there was subtle leptomeningeal enhancement. We didn't call it MOGAD, but what we did think of was, it could be infection, but what was atypical was just the unilaterality of involvement. But of course, we have very bright clinicians, and they went ahead and tested this, and this turned out to be positive for MOGAD. So this is an entity known as flames, which is essentially flare hyperintense lesions in anti-MOG associated encephalitis with seizures. With respect to the demyelinating disorders, we have MOG is one of those conditions that responds beautifully well. And as you can see here, again, you do see flare hyperintensity involving those sulcal spaces. And this was another case that was brought to us. So now, what's important with respect to seeing these kind of cases is when we saw the previous case, we really didn't think along the lines of flames. It was a rather new and growing entity then. But this patient that came to us just a couple of weeks back, we were able to quickly pick on this diagnosis, pick on the finding, and also raise the suspicion of MOG. Now, one thing that I would reiterate is the importance of SWI in such cases. Sometimes when it may be sort of dubious to call it flare hyperintensity along the sulcal spaces here, but when you do see leptomeningeal enhancement and you do see this paucity of, susceptibility on the right side, as opposed to the left, that's when you're sure that, the finding is probably clinically significant. So we were quick to pick on the diagnosis of, not the diagnosis, I think it was rather a differential that was placed in this case, but the patient did respond remarkably well. And the follow up after a couple of months itself shows a resolution of the signal changes and also this reinstitution of the normal SWI. So this is one of my penultimate cases. So this was a case of lupus encephalitis, just a reinforcement that ANA positive cases can also present to you with psychiatric illness and perioral tremors. So in such cases, again, go back and look at the brain. As is seen here, there is involvement of the hypothalamus, the thalamus, as well as the brainstem with variable volume loss. So this is just a 24-year-old female. So of course, the volume loss is disproportionate for the age of the patient, not at all commensurate with the age of the patient. And this was a case of lupus encephalitis. So having said that, I would now like to open this case to the audience as to what do you think the diagnosis of the index case that I showed was? Is it just run of the mill HSV? Should we consider some other etiology as well, or maybe it's just sufficient for a radiologist to call it encephalitis, sequelae of encephalitis? Is there any way that I could know if the audience is answering this?
Yeah, so we have the chat box also and the Q&A. We have two places. Um,
Okay. Okay, I see Himani answering autoimmune. Yes. Okay. Anu says it's HSV only. All right. So so essentially it is one of those cases where it turned out to be positive
yeah.
for HSV as well as NMDA. So
Wow.
yeah, I mean that's just the beauty of radiology and science in particular, that you can never be right. You can never always be right. So this is my parting slide. So like I said, look at the onset, look at the CSF, look at the MR, talk to the clinician, most important, and then decide on what exactly could be happening in the patient. So this is my beautiful department, my wonderful residents that keep me going. Thank you so much.